Today we are going to discuss the most common rheumatological problem, that is rheumatoid arthritis. Hi friends, I am Dr. Rajkiran, Managing Director, HRC Hospitals, Hyderabad. Patients with rheumatoid arthritis, I'll tell you detail what kind of treatment modalities are available. So instead of taking proper treatment, if they completely depend upon painkillers or steroids, which will only reduce the symptoms but do not cure the disease. If they are dependent on those particular drugs and if they keep taking them regularly, there are chances that they might develop cardiovascular problems. So all these things could be late complications of rheumatoid arthritis. So we need to see that none of them develop these problems over a period of time. So our goal when we start treatment would be to see as soon as possible to control the disease, to bring the disease into remission so that your medicines will be minimized to as low as possible and see that you doesn't develop the late complications of rheumatoid arthritis. Sometimes patients also can develop red patches on the skin ulcers. So these are called vasculitic ulcers. This also can be a delayed complication of rheumatoid arthritis. And friends, coming to the treatment options. So what treatment options we have to treat rheumatoid arthritis? So basically the treatments are divided into the medication part, the physiotherapy and the lifestyle modifications. So first I'll discuss about the medicines available to treat rheumatoid arthritis. So in the recipe of rheumatoid arthritis treatment, we have three types of drugs. So the one is the symptom modifying, because patients with rheumatoid arthritis have severe pain, so they will be suffering. So the first and foremost goal is to reduce the pain. So for that, to control the symptoms, so we have to give a symptom modifying drugs. I'll come back and tell you what are the symptom modifying drugs. The other drugs which we use are the disease modifying drugs. So these are the drugs which aim at controlling or curing the disease or modifying the disease into a stage where the patient goes into remission, where they might require a very less doses of medication or they might not require any medication. The third drugs are supplements like vitamin D, calcium or a gastric medication. These are all supplements. So we categorize broadly into these three groups. Symptom modifying drugs include painkillers and steroids. So these are used with caution because doctor who is expert in using these medications will prescribe by looking at the patient's age, general condition and the other comorbid problems. Comorbid problems means like other conditions what they are suffering with, like diabetes, hypertension, cardiac, renal, liver disease. So doctor will prescribe the medications taking all these things into account. So which suits you better. Like one pill is like it doesn't fit to everyone. Like it's the same pill can't be given to everyone. So looking at their background problems and looking at the investigations like what is the blood status and what's the kidney status, what's the liver status, looking at that and what is the amount of severity of the disease. Looking at that, we prescribe the doses of the pain medicines or steroids if required. But these medications are not very good in long term. So we use these medications only for a short term, for maybe few weeks or few months till your symptoms get better, till your major suffering or severe suffering comes down. So these are the medications we use for very short term. So symptom modifying drugs are very short term. So patient should not feel like if I am taking this drug, I am feeling better and I'll continue this drug for a longer time. And for me, because I am getting better with this medicine, no need to meet doctor. So there should not be this kind of assumption. Pain medicines or steroids should be taken only for a shorter period of time whenever it is required. So now coming to the most important aspect of treatment, that is disease modifying drugs, the drugs which has a potential to cure the disease. But these drugs won't act immediately. So when I start a medication to cure the disease or control it properly, so the medications will take at least 1 month or 2 months to 6 months time to control the disease. So till then we take the help of the pain medicines. So we have lots of disease modifying drugs available today. So we broadly classify these drugs into conventional synthetic drugs and biologic drugs. So these are the two different types of drugs, and we also have a targeted synthetic drugs. So these are the scientific names which we give to these drugs. The most common medication and the gold standard therapy and the first line of choice which we use in treating the patients suffering with rheumatoid arthritis is methotrexate. So methotrexate is the most commonly available drug, so which we use to the patient suffering with rheumatoid arthritis. But as I said, so these drugs should be used with caution and it has to be prescribed only by the doctor who is expert in treating this disease and who have an experience and proper training in handling the complications if anyone develop while using these drugs. So it's not like a go-go medicine, take it and pop it. So it has to be prescribed after thorough checking, evaluation. If your body suits, if your body like doctor feels if it's required for your body, doctor feels it suits to you, then only we'll prescribe. So methotrexate is the initial drug, the most common and widely used drug. Apart from methotrexate, we also have another drugs like leflunomide, sulfasalazine, hydroxychloroquine. So these are the drugs which we use individually or in combinations. Okay, so like who tells us to use this drug or combination of the drugs, or if this drug doesn't work? If this drug doesn't work, we use another drugs called biological medicines. These are the injections, so which are available. So I'll come to that. What are the injections that are available? So who tells us how to begin the treatment and how to follow up the patient, how long to use, what medications to be changed? So there are certain associations, certain societies which will observe the research happening over a period of time, and they will formulate the guidelines which comes once in 4 years or once in 5 years. They will come with the guidelines and they will give it to us. They get published and then we'll look into these guidelines. So the major associations which develop these guidelines are American College of Rheumatology, EULAR, that is European League Against Rheumatism, and Asia Pacific League Against Rheumatism, that is APLAR, and IRA, Indian Rheumatology Association. So we have these four bodies. One is ACR, the American body, one is European body, EULAR, the other one is APLAR, that is Asia Pacific Region Association, and the fourth one is Indian Rheumatology Association. So these four organizations, looking into the native population and looking into the research happening in that particular area, collecting the data, they will formulate a guideline like, yes, so you have to diagnose this disease, and once you diagnose, this is the way to diagnose, these are the tests to be done, and once these tests are done, then this is what should be the medication which has to be started. And once we start medication, like for example, the most recent ACR EULAR guidelines which are published in 2023, that tells us like if once you start methotrexate, if the patient is not responding in 3 months, then you have an option to add another drug, or you can give an option of adding a biologic drug or a targeted synthetic drug. So this is how, as a doctors, we update ourselves looking at these latest guidelines and latest treatments available, so which comes from the research conducted in vast number of patients. So even in our hospitals, especially HRC is a dedicated hospital for rheumatology patients. So we collect data and we are a part of IRA database. So we collect the data and we keep analyzing the patients, which patients are improving, which patients are not improving. So we keep analyzing the data every 4 to 5 years and see which suits best for our patients, and we come up with the specific protocols to see that our patients do well. So once the routine drugs like methotrexate, sulfasalazine, hydroxychloroquine, once they are tried and the patients are improving, it's good and fine. We'll continue with these drugs, and once after 6 months or 1 year patients are doing better, we'll try to de-escalate the doses and we'll try to minimize the doses to as low as possible. If the patients are doing better, we try to give a break to the medication. Suppose if the patients are not doing well with the routine drugs, so we add these newer drugs, the biologics. So the most commonly used biologics in our country to treat rheumatoid arthritis are rituximab injections, etanercept injections, and infliximab and adalimumab. So these are the four common drugs, and we also have other drugs like Simponi, golimumab, and we have Actemra anti-IL-6 drugs. So these are the various biological medicines which we use to treat our patients. So these therapies are a little bit expensive, and they also have certain guidelines, they also have certain risks and complications. So in 2016, when these drugs have become available, so we have published one article in Indian Journal of Rheumatology, that is checklist to be done before prescribing these biologics, because these medicines have a risk of causing complications, like they might reduce immunity a little bit. So infections might come as a complication. Again, so we will always check whether it suits the patient or not, and if we feel it will work for the patient, then we will give them. Routine medications are not working, they are not helping, then we will decide which of these medicine needs to be given. So certain tests need to be done before giving these medications. So that we have published in our article in IJR in 2016, checklist before biologics in an Indian perspective. So once we see everything like this particular medicine suits this patient, so then we will prescribe these medications. These medications are expensive, not easily reachable to most of the patients, but still people can manage to take this. So drugs like rituximab, the therapy might cost around 25,000 to 40,000, and similarly drugs like adalimumab might cost around 10 to 15,000 per month. For 6 months at least we need to give. Similarly, etanercept also might cost that much. But these drugs do work very well, and those patients who don't respond to routine therapies. So as on today, we have reserved these drugs to the patients who do not respond to regular therapies. Those people who do not respond to regular therapies, we choose these drugs, and they do 95 to 98%. There are chances that they do extremely well by using these drugs. Only thing, with an experience, it has to be used only by an experienced person who can utilize, who have an experience of handling these drugs. In HRC, we have more than 1,000 patients who are on these drugs, who are on regular follow-up. The complication rate is very, very minimal. I can say less than 1%. That is because of robust early identification, robust early checkups, and looking at these patients, like who are the suitable candidates. So we need to identify who are particularly suitable or eligible to take these therapies. So once you identify this patient, then the right patient is important. Once you identify the right patient, then it's quite easier to give, and the responses also would be very, very good. So very rarely, suppose patients do not respond to these regular therapies or could not afford, sometimes we also inject the joints. So knee joints, if they are swollen up and a lot of fluid got accumulated, or the wrist joints, elbow joints, we inject local medication there, so that will also give a good amount of relief to the patients. So these are the various medications available to treat rheumatoid arthritis. Apart from that, joints can become very stiff. So we ask our patients to do regular exercises, mobility exercises especially, so that the stiffness of the joints can be avoided, and we can see that the patients do not develop deformities. Regular exercise, simple exercises like yoga or physiotherapy. So we like in our channel, we also do have certain physiotherapy exercises told by our physiotherapist. You can also, when you get time, you can go through that physiotherapy exercises. And most important thing is our lifestyle modifications. Avoid sedentary lifestyle, avoid sitting and sleeping for a long time. Keep moving. Do moving, walking or something, but staircase climbing sometimes may be harmful. Better to avoid as much as possible, and try to keep moving, walking as much as possible, so that you don't become stiff. Prolonged sitting is also not advisable for the patient suffering with rheumatoid arthritis. Simple movements even in the sitting position also might help. Smoking for men, especially if they are smoking or tobacco chewers, the medication might not work properly, they might develop complications. That should be avoided. Alcohol consumption might interfere with the medications, it might lead into liver problems. That also should be minimized or avoided. And diet, like heavy meat eating also, if it is better, you can reduce it. Shift to more of a vegetable diet and more of fruits, and hydrate yourself properly. Once in a while you can consume wheat, boiled eggs, these are all fine. So these things can help. Little bit modifications in your diet, not too much changes are required, because this might again alter gut microbiome and might lead to other complications. So little bit modifications in your diet might help to recover you faster. And like once you have been diagnosed as rheumatoid arthritis, most important thing is, once you get diagnosed as rheumatoid arthritis, you should not get depressed. You should not feel like I have to take medications for lifetime. Do I need to take medications for lifetime? Does my life will be like this throughout, or I'll not be able to do all routine activities or like normally. So one should not feel low, or one should not feel negative, because this itself might create more problems, and the disease might worsen with lot of stress and depression and anxiety. So feel nothing had happened to you. Your doctor will take care of yourself, gulp medicines and do your work like as normal. So this is the best strategy one can apply. Best is to forget your disease and keep moving. So this strategy, if you apply, you might also recover faster. You might not feel your pain, you might not feel your suffering. So this is the best way to handle, which I'll tell to my patients. So like the long-term problem, sometimes if not treated, the joints can get affected, the knees can get damaged, might end up with knee replacements to some patients. So the knee replacement surgeries, if they are done, so we will take proper precautions to see that in which stage the patient has to be subjected to surgery. So knee replacement surgeries for rheumatoid arthritis are different from knee replacement surgeries in regular patients like osteoarthritis, like elderly people suffering with knee pains. So knee replacement in them is different from knee replacement in patients suffering with rheumatoid arthritis. We need to control the disease well. Once the disease is controlled, then only we need to subject for rheumatoid arthritis, and the bone quality is very weak in patients suffering with rheumatoid arthritis. So sometimes we might require different implants in patients with rheumatoid arthritis rather than patients in osteoarthritis. So we look at all these things before like pushing the patient into for a knee replacement surgeries. So friends, I hope you got a rough idea about rheumatoid arthritis, the causes and whom it affects normally. And it is estimated that 1% of our population suffers with rheumatoid arthritis. So it's a reasonably high number. And who are the people who get affected with rheumatoid arthritis, and what are the precautions to be taken to prevent the complications of rheumatoid arthritis, what are the medications available as on today, how your doctor arrives to the diagnosis of rheumatoid arthritis, what are the treatments offered and what are the latest treatments offered, what are the complications in RA. So everything we have discussed today. I might have missed a few, but if you still have any questions, please write in our comment box. Definitely I would like to answer them. Thank you very much, friends.